Okay, good afternoon, everyone, or whatever the time is in your particular time zone. Thank you so much for joining us today for this GBD 2023 session here at the Institute for Health Metrics and Evaluation. Today's session will focus on a closer look at non-fatal diseases, injuries, and risk factors. My name is Johan Månsson. I'm an Senior Engagement Officer here with IHME at the University of Washington. And I'd like to extend a warm welcome to all of our collaborators joining us today. Today's session is the third topic in the GBD 2023 focus series, where we aim to provide an overview of GBD 2023 results by taking a more in-depth look at each of the three capstone publications for this round of the GBD. We're very fortunate today to be joined by Dr. Damian Santomauro as our presenter. Dr. Santomauro is an affiliate assistant professor of health metric sciences here at IHME. He's also a research fellow at the Psychiatric Epidemiology and Burden of Disease Research Group based at Queensland University, the Queensland Centre for Mental Health Research, in Queensland, Australia. He's also an affiliate assistant professor here at IHME. For his work on the global burden of disease study, where he's responsible for the epidemiological modeling of autism spectrum disorders, fetal alcohol syndrome, and alcohol dependence. Dr. Santomauro's PhD investigated emotion regulation in adolescents and young adults with ASD, and the project involved managing the first randomized control trial of a group cognitive behavioral intervention targeting depression in adolescents with ASD ever conducted. Dr. Santomauro has a keen interest in statistics and research methodology and currently acts as Peabod's resident statistician. Before I hand over to Dr. Santomauro, I wanted to do some light housekeeping. In today's session, we'll spend the first half looking at the critical findings across all three capstones, following which we will have a 20-minute questions and answers segment where each of you will have the opportunity to pose any questions you may have. Out of necessity, we have our microphones muted, and so if you want to ask any questions, we encourage you to use the Q&A function. And please do so throughout the session, and we will get to responding to them at the end of the presentation. But with that in mind, I would like to hand over to Dr. Santomauro. Damian, take it away.
Thank you so much, Johan. Hi, everyone. I'm Damian. I'm the Mental Disorders Team Lead and also the DISMOD AT Lead for GBD. I'll get started by sharing my slides. Let's see. There we go. So I'll be taking you through a closer look of the non-fatal results. So the results have now all been published for GBD 2023. We're all very excited. We've had the capstone publications in the Lancet. And the Lancet also has a dedicated page to GBD. You can go there on that link on the slide there, where you can also look at old previous iterations of GBD, but we always say you should really stick to the most latest one. And there you can find the capstone papers along with any kind of cause-specific papers that are, or location-specific papers that are published also in the Lancet family journals. So before I start going into the results of the GBD study, I first want to do a bit of a conceptual recap of the primary metric that we produce in disability. So in GBD, sorry. In GBD, our primary metric is this DALY, this disability adjusted life year. But I think to a lot of people, this can just be a number and not necessarily have kind of a conceptual or intrinsic meaning or value. And so I thought I'd start, before I start presenting DALYs all over the page, I might just quickly go through, just so we understand what exactly a DALY is. So I want you to imagine that you're living your long and healthy life, you're living your healthy life, you get to about 40 years of age. So this is your timeline from when you're born to, say, about 40. And then when you reach 40, you develop a condition. I like to use alcohol dependence as an example because it has both fatal and non-fatal health outcomes. So say at the age of 40, you develop a condition or disorder, let's say alcohol dependence, and then you live with that disorder for 20 years between the ages of 40 to 60. Now, let's say it was severe alcohol dependence and the disability weight of that, or let's say, sorry, I'm jumping ahead. Those 20 years that you've lived with alcohol dependence, that burden is captured in the years lived with disability or the YLDs. This represents the non-fatal health loss. And the way we quantify this is by we're trying to work out for every condition that we estimate YLDs for, how many people are actually living with that condition or that state right now, or for the year 2023, or for each year that we're estimating for. And then each of those states has a disability weight associated with it. And the disability weight is a value between 0, representing perfect health, and 1, representing death. If you have a disability weight of 1, your health state is the equivalent of death. So the idea here is that if you have a disability weight, say if you have a disability of zero point 0.5, living with that condition is the equivalent, is like passing away 6 months earlier than you're expected, than your life expectancy. If you live with that condition for 2 years, it's like passing away 1 year earlier. So when we quantify for 20 years, let's say you had severe alcohol dependence with a disability of zero point 0.5, for 20 years, that's the equivalent of 10 years of life lost, equivalent. And so that's the way kind of YLD can be conceptualized. It's how many, it's on the same level as years of life lost. So those 10 years, you've lived with it for 20 years. It's the same health loss as passing away 10 years earlier than you're expected to live. But let's say at 60, the alcohol dependence did kill you, because alcohol dependence can take lives away, and you're expected to live to 80 years of life, just hypothetically. That disorder has robbed you of 20 years of your life. So 20 years of life lost. So then we add together the 10 years of YLDs to the 20 years of YLLs, so the fatal and the non-fatal and the fatal together to give the total DALYs for this disorder for this person. So it's 30 DALYs for alcohol dependence for this person. And then we do this across the board at the population level and kind of snapshots at any point in time. And for the year 2023, what were the YLDs and the YLLs for a particular condition, and then what was their subsequent DALYs. And GBD has been doing this for many years. It first started in 1990, first led by Chris Murray and Alan Lopez. And then there was a WHO kind of update to this in the 2000s, early 2000s. And then from GBD 2010 onwards, IHME, took lead and began really expanding how many disorders and diseases and injuries that they model for, started doing country level estimates and more granular points in time. And now we're up to GBD 2023, which has just been released in October. We're now up to 375 diseases and injuries across 204 countries and territories, 25 age groups, and then now we provide estimates for every year between 1990 all the way to 2023. And 2025 is already in progress. But this will be, GBD is always a very long exercise, so watch this space. For now, GBD 2023 is the best public release of estimates. But we're always busy now working on GBD 2025. So, like I said, GBD 2023 produces these metrics for 375 diseases and injuries, by age, by sex, and by location. We provide estimates of prevalence and incidence of years lived with disability, that non-fatal health loss, also the years of life lost, so the fatal health loss of that condition, the total health loss, combining those two together, the fatal and the non-fatal together in DALYs, disability adjusted life years. And then we also produce healthy life expectancy, or the HALES, quantifying the expected years of life lived in good health. And I won't be focusing on HALES today. I'll be mostly focusing just for time on YLDs, on DALYs. And we provide these estimates as counts, but also as rates, as all age, and age standardized and age specific. So we do provide, by location, all age and age standardized, and which one you use might depend on what you're after. General advice I have is that if you're wanting to look at the true prevalence in your location, the all age is better because it factors in the population distribution of the location you're actually looking at. But age standardized standardizes the population, the global population, so that every country essentially looks like they have the same population distribution. And this is good for comparing countries against each other. If you say, oh, well, if they had the same, demographics, how do they perform against each other? What are the most burdensome disorders between those conditions? But if you are more interested in your local true rate, the all age would be better. And so we include quite a lot of data sources in GBD 2023. We include data on prevalence, on incidence, remission, severity, duration, mortality, excess mortality, cause-specific mortality. To estimate DALYs, it was informed across the board by over 120,000 data sources, of which 35,000 were new for GBD 2023, including more than 50,000 on incidence, 25,000 on prevalence, and the remainder on measures such as severity, duration, etc. And then on the risk factor side space, so this is, we've got in GBD, we report DALYs due to the conditions, but we also report on the effects of risk factors. So what is the avertible or burden that could be prevented through modifiable risk factors? And this is informed by over 59,000 data sources, of which 16,000 were new in GBD 2023. We have more than 55,000 informing the exposure to risk factors. So, how many people drink, how many people are smoking, but those kind of how many people are actually exposed to that risk. We've got over 55,000 data sources informing that. But we've also got almost 4,000 sources informing the actual magnitude of that causal risk. So the relative risk information, how much does smoking actually causally lead to lung cancer, and what is the magnitude of that effect, for example? So you have over 4,000 sources on that. And all of these sources can be looked at through the GBD 2023 sources tool on GHDX. So there's quite a few new things in GBD 2023. Again, we have over 35,000 new sources for informing the prevalence and burden of diseases and injuries, and over 16,000 for risk factors. We have 5 new causes, so ulcerative colitis, we've got Crohn's disease, thyroid diseases, other endocrine, metabolic, blood and immune disorders, and also electrocution. And we've also included 50 new risk outcome pairs. This is a tremendous effort. And I say this because I feel like I can say this without bragging, because it wasn't my team that did this, but I was so impressed by how many new risk outcome pairs were done in this round, because there's a lot of work involved in generating a risk outcome pair and quantifying in a causal manner what that risk actually is. So this was a tremendous effort. And then we've also removed the other pandemic-related outcomes from the cause list. So for GB 2021, we had this cause called other pandemic-related outcomes, and it was to reflect the unexplained excess deaths during the pandemic. That we could see that there were excess deaths in certain locations, but we didn't have enough.
Looks like we may be having some technical difficulties. Give us a moment here. Apologies. Okay, folks, apologies for that. Damian is going to try to rejoin us here. Please give us a minute as we sort this out. Welcome back.
So everyone, my internet has cut out. I'm now hotspotting on my phone. Let me just reshare. All right. So as I was saying, Dismod MR is our go-to modeling software for estimating the epidemiology of all our conditions or most of our conditions. It's very powerful in that you can feed it estimates of prevalence, incidence, remission, and mortality, and it will come up with very plausible estimates of the prevalence and incidence of the condition, which is what we need to estimate YLDs, and can incorporate covariate effects to help inform prevalence. So one example I like to use is for alcohol dependence. We might not have information on how much the alcohol dependent prevalence for everywhere in the world, but we do have a better sense of how much alcohol is sold in each country in the world. And so Dismod can estimate what that relationship is between our data, our prevalence data of alcohol dependence, and how much alcohol was sold, find that association, and then use that to help extrapolate what the prevalence might be in other countries where we don't have any data. And so it's very powerful in this manner. But there's this new and latest, greatest version called Dismod AT, which we're all very excited about. It seems to be performing way better than Dismod MR at following the data, and it's much better at incorporating age and time trends and cohort effects as well. And so we began this migration process for diabetes type 1, for major depressive disorder, anxiety disorders, and autism, because we knew that these were conditions that we didn't feel like Dismod MR was doing justice for the time trends for these conditions. And so we tested putting these into Dismod AT for GB 2023. Across the board, there's also been additional methodological improvements across the causes, so updates to severity. We've included many more bias corrections, for example, across the causes, as well as other improvements. Now, I do want to walk through, very quickly the general methods of how we estimate DALYs for GBD. Now, I appreciate this is a figure that many of you might have seen already in cause write-ups and kind of maybe just glanced at and gone nut, and then scrolled away or looked away. And I get it; it's not a very nice or friendly figure when you look at it all at once, but it's a fantastic kind of map that if I hone in on different sections, it actually explains the process very quickly and easily. And I hope that I convince you of that in the next few minutes. So if I break this down, our very first step is just compiling all the data we can on that condition. We might do literature reviews. We might look for known registries of that condition. We might look for clinical or claims data, depending on the condition. It really depends on the condition, how appropriate different data sources are. But we'll combine all the data. Sorry, everyone, my internet is not performing very well. Give me 1 second.
Damian, would you prefer that I share the screen for now?
I'm hoping it's stable. It doesn't usually do this. If it continues, then maybe yes. It's just that there's a lot of animations on the slide that let's see how we go. So we first start, we compile the data, all the epi data we can. Then we try to standardize that data. Really, we want data that's going into major depressive disorder. We want that condition to be, we want all our data to be representing the clinically diagnosed major depressive disorder, but maybe all the data is symptom scale data. And so we'll have bias corrections for that kind of data as an example. And once all of our data has been bias corrected and standardized to represent what we're trying to model, that then goes into a Dismod MR model or AT model, depending on the condition, where we then model the prevalence for every age, sex, location, year. And so this produces all of our prevalence estimates for those conditions at that granular level. But then many of our conditions, the disability or the YLDs will vary by the severity of that condition, whether they're mild, moderate, or severe. So for example, for anxiety disorders, from memory, the mild disability weight, I think, is around 0.03, where the severe is around zero point 0.5. So quite a substantial difference. So we need to know the information of how much are mild, moderate, and severe, or depending on, those states or those categories will differ depending on the condition. But what we tend to do is we then look to the smaller number of data sources that inform this information, whether it's maybe it's a systematic review or meta-analysis, estimating what that distribution is, or maybe it's one source or a survey. But regardless, there's an analysis, separate analysis there that provides this just information on that severity distribution. And that's used to estimate from the prevalence what the severity specific prevalence would be. And once we have the severity specific prevalence by age, sex, location, year, each of these states has a disability weight. And so we will multiply these prevalences by their respective disability weights. And that will give us the crude YLDs for that population. Then we do a comorbidity correction because if if someone is living with multiple conditions that have high disability weights, it could be a scenario where that person's disability weight or cumulative disability weight exceeds 1 or exceeds a state of death. And we say in GBD, you can't be less healthy than dead. So there's a comorbidity correction here that we do to make sure that no one's disability weight exceeds 1, that there's no kind of overlapping symptoms or disability, and that the YLDs can be added together. And when you add them together across all the conditions, they won't actually exceed, the total possible years of life in the population. Then we factor in YLLs. So that gives us comorbidity adjusted YLDs. Then we factor in YLLs into the mix, and that brings us our DALYs. So the YLLs, they're informed by various data sources like vital registration, verbal autopsy, registry, survey, and so on. And in GBD 2023, we follow the principles of ICD, where a death is assigned the underlying cause that initiated the events leading to death. And this is often a contentious point, for example, for the mental disorders, where we're often told, where are the deaths due to mental disorders? But according to ICD, mental disorders are rarely, if like almost never assigned the underlying cause of death. Usually it's the the injury, for example, that's marked as the cause of death. More mental disorders definitely elevate your risk of death, but it's not the ICD underlying incident that led to the death in question. So that's where it's very important to make this distinction clear. And most deaths are estimated using this cause of death ensemble model or CODEM, which is it's an ensemble of statistical models while also systematically testing for combinations of covariates on the basis of their outer sample predictive validity. And this estimates deaths by location, age, sex, and year for a given cause. Then once we know who has died, where, and how old they were, and how long, we also know what their expected life expectancy was. And so we can calculate, well, how many years of life did these people lose? We add those YLLs, and that's how we get our YLLs for every age, sex, location, year. And these are added to the YLDs to calculate DALYs. And more on YLLs were covered by Professor Nagavi on the October 23rd, and that would have been recorded. So you're very welcome to listen to that recording. So the GBD 2023 results, they're summarized in the GBD publications that will come out, whether it's the Lancet capstone or the disorder-specific papers along the way. They're also available on GBD Compare. So that if you follow this link, it'll take you to GBD Compare, which I'm hoping many of you are familiar with, where you can go through all the cool visualization tools and explore the data. But then if you want tabulated data, you can go to the GBD results tool. The only change this year is that you will now need to create a free account to log in to access the data. Previously, it was all open. You didn't need an account to log in. Now we've put in that you do need a free account, but it is free, but you just need an account. So now on to the actual results. So this picture here represents all of the burden, all of the health loss of the world in one picture. This is called a tree map, but I've never understood why it's called a tree map. I like to call it a cake chart because it's basically a square pie chart. And each square here, if you picture it like a slice of cake, how the bigger the slice of cake, the more burden that the these disease. It explained nearly 200 million DALYs globally. And again, this is the if you think about this, this is the equivalent of 200 years of equivalent life lost. Um, so it's quite a large number. We've also got neonatal disorders. So I should also explain that the blue here represent the non-communicable diseases. The red here represent the communicable, maternal, neonatal, and nutritional diseases, and the green represent the injuries. And the depth of the color, so the darker the color or the stronger the color, represents the increase, annual increase between 2010 and 2023. So, for example, you can see diabetes have increased a lot, anxiety disorders has, Alzheimer's has, for example. We've also got 170 million DALYs due to neonatal conditions, neonatal disorders, and then more than 150 million due to stroke. And what's interesting now, or shocking to me now as well, was that NCDs now account for nearly 2/3 of the global DALYs. So we're definitely seeing this shift towards NCDs. Now, breaking this down into actual patterns by age and sex, we can start to see some patterns here. So you can see this figure on the top is females, and the bottom is males. On the y-axis, I think I mirrored it from your perspective. On the y-axis are the counts of DALYs, so how much burden is being caused at that age group. On the x-axis are the different ages in years from for most part, but then on the left here you can see it's kind of a bit more granular in that first year, and the different colors represent the different disorders. And you can see in very young, we've got a lot of the neonatal conditions causing a lot of YLLs. So if there's someone that passes away at this age, they essentially lose their entire life, and so there's a lot of YLLs here. But then as we move into the older ages, we start seeing the impacts of mental disorders towards the kind of adolescent teenage years, and then as we get older, we start seeing musculoskeletal disorders, neoplasms, cardiovascular diseases, and then the burden starts to taper off as people get older and pass away. For males, overall, they experience more burden than females of 1.5 billion DALYs, and females experience 1.3 billion DALYs. And overall, the DALYs peaked around the 65 to 69-year-olds at nearly 200 million DALYs. So this figure here illustrates trends in the total DALYs and the DALY rates by SDI and by cause group. So we've got blue here. On the left here, we've got global. And the blue here represents the non-communicable diseases. So you can see that globally they are skyrocketing. In the red represents the communicable diseases, maternal diseases. They're decreasing with time. You can see the spike due to COVID, but they are fortunately decreasing. And then injuries kind of remaining stable across time. And then we have the age standardized rates on the bottom here. And overall, DALYs have increased by about 6.1% since 2010, but this has mainly been due to population growth and aging. As people, as the population grows, there's going to be more DALYs to count. But the age standardized DALY rate has fortunately decreased by nearly 13% since 2010. And the largest improvements are in the communicable, maternal, neonatal, and nutritional diseases. We've seen a decrease of almost essential DALY. So I'm getting a warning about my internet again. There is a substantial increase of the DALYs due to NCDs of 350 million. But fortunately, the age standardized rates have decreased by 4.1%, but it's still much smaller than the communicable diseases. And low SDI locations still bear the greatest burden of the communicable, maternal, and neonatal and nutritional diseases. So you can see, looking at some patterns here, what I find quite interesting is that there's very steep, great, fantastic gains or reductions in health loss when you look at the rates for the communicable diseases and low SDI, well, across the board, but most notably in low SDI. So there's been fantastic progress, but it is still, when you compare this to higher SDI locations, it's still not acceptable. And then we're seeing some gains in NCDs in the mostly in the high and middle SDI, but some also in the high SDI. But hardly anything and very little progress for low SDI locations. This figure here illustrates the rankings of the disorders. So on the highest, the causes kind of ranked at the top are the most burdensome disorders, and we've got different columns for different years. On the left here, we've got 1990. In the middle, we've got 2000, then 2010. And on the far right, we've got 2023. And then on the very far right column here, we've got the change, the percentage change in age standardized DALYs since 2010. And one thing that's kind of interesting is that you'll see that across the board there's this shift where the NCDs are really climbing up the ranks. The blue here again are the NCDs. So we're seeing that the red conditions, the communicable diseases, and maternal diseases, and neonatal, they're all kind of decreasing in rank, and the non-communicable diseases are starting to climb. But we should acknowledge some fantastic gains. We've had 40 to 50% reductions since 2010 in diarrheal diseases, HIV/AIDS, tuberculosis, and also great gains in malaria. It's dropped 21%, and neonatal disorders have dropped 16% since 2010. But the leading causes, like I mentioned, they're dominated now by non-communicable diseases. We've got ischemic heart disease now the leading cause of burden for 2023. And we've also seen large increases from 2010 for diabetes, for depressive disorders, and for anxiety disorders as well. The next, I want to move on to risk factors. And so this was a very, for me, was a bit of a shocking result, was that almost half, and this is also a great reflection of the amount of work that was done trying to, getting more risk factors in risk outcome pairs into GBD, that almost half the global health loss was preventable through modifiable risk factors. So this plot here, again, illustrates the total burden in 2023. It's essentially the same plot that I showed you before, but the colors here are different. The shading is different. Here now, the shading represents how much of that burden is explained. So for example, the total burden, diabetes is completely full. It's completely colored in, which means that all of the burden of diabetes is avertable. Same for CKD, a lot of the neonatal burden, a lot of the diarrheal diseases, a lot of stroke. You can see just how much burden could be avoided. This is half of the total health loss of the world could be averted. This was very shocking to me. I wanted to make a point of this. And you can see on the right here, we've got trends of this figure illustrates trends of risks, of the risks, different risk categories. We've got behavioral risks in blue, environmental, occupational in red, and then metabolic in green. And these two plots track how their contribution to DALYs over time. So we've got counts on the left plot here, and then the rates on the right here. And you can see, behavioral risk factors, environmental, occupational, we have seen these kind of these declines over time. But for metabolic risks like high fasting plasma glucose or high BMI, we're seeing an increase of 31% nearly since 2010. And the age standardized rate, I think, is quite stable across time. We've seen gains or improvements in the other risk factors, but very little improvement in these metabolic risk factors. And in fact, I think I mentioned on the subsequent slides that high BMI is increasing, for example. So this figure here is a similar figure to what I showed before, where the ranking of the causes, but now it's the ranking of the risk factors. So these are the most burdensome risk factors in 2010 on the left column here, along with their percent of total burden, how much of the total burden they explain. Like in 2010, particulate matter pollution explained 9.3% of the burden. On the right here are the risk factors for 2023, and you can see a lot of these metabolic risks have increased in their rank. High systolic blood pressure has now outranked particulate matter pollution, explaining nearly now 8% of the burden of the total population. So again, there are some notable gains here. We've got 40 to 50% reductions in unsafe sanitation, unsafe water source, not having access to safe hand washing facilities, and child growth failure. These are all tremendous gains. And also smoking has dropped the burden due to smoking has dropped by 25%. But there are some worrisome increases, like I mentioned. We've got high BMI, we've got high fasting plasma glucose going up, we've got drug use increasing as well. And then just to go through some geographical patterns of these risk factors, we've got high systolic blood pressure, which is the most burdensome risk factor. So I'm getting another warning about my internet. We'll see how this goes. We've got high systolic blood pressure, the most burdensome risk factor that we model in GBD, and mostly impacting North Africa, Middle East, Sub-Saharan Africa, and East Asia, South Asia, Eastern Europe, Southeast Asia, East Asia, Oceania. So many regions around the world where this is a very burdensome risk factor. And then we've got particulate matter pollution. This is very, very dominant in South Asia, not Sub-Saharan Africa, North Africa, Middle East, and East Asia, as well as Southeast Asia. We've got smoking, very prominent in Eastern Europe and China, so East Asia and also Southeast Asia, and also several parts within Europe and North America, and very high in Greenland. And high fasting plasma glucose. We've got Central Latin America really experiencing a lot of burden from this risk factor. Again, North Africa, Middle East, and Sub-Saharan Africa, South Asia, and Eastern Europe, and Southeast Asia. Low birth weight and short gestation. Sorry, I promise I've only got two more of these. Low birth weight and short gestation. We've got mostly Sub-Saharan Africa and South Asia. And then the last one I put in, this is the sixth most burdensome risk factor, but I wanted to emphasize, high BMI is now, fast becoming one of the risk factors that's actually increasing. The burden is increasing with time, and across many places around the world, this is an issue. We've got US, Mexico, Latin American, Caribbean, again, Eastern Europe, North Africa, Middle East, some places in Sub-Saharan Africa. This is one that this is a risk factor to watch. This is the emerging one. So looking at all these results, there are some takeaway messages there are some messages I think we can take away from these results. One that really stood out to me was that, again, nearly half the global health loss in 2023 was preventable through modifiable risk factors. Again, nearly 46% were due to these risk factors. The top 5 risks included high systolic blood pressure, particulate matter pollution, smoking, high fasting plasma glucose, and low birth weight or short gestation. I think targeted prevention could dramatically reduce this health loss by trying to increase healthy diets, physical activity, better tobacco control, and also improving air quality. So, and before I move on from this, there's another thing I want to emphasize that typically within GBD, the risk factors we model or estimate are the ones that we have been able to compile enough evidence to show that causal direction, show that causal risk. So what I'm trying to emphasize here is that this 46% are due to our known modifiable risk factors. So I actually conceptually see this as an underestimate, and that some of these risk factors would actually even explain more burden, maybe for other conditions that we don't have any of the data to show that relationship with. So I would see this as an underestimate. I really, really want to emphasize the potential benefits of actioning these. The other is that historical progress on communicable, maternal, neonatal, and nutritional diseases is fragile. We've had tremendous gains, a 26% reduction in these disorders since 2010 in the age standardized rate. We've had major declines again in diarrheal diseases, HIV, tuberculosis, malaria, and neonatal disorders. But the burden is still highest in low SDI locations, especially in Sub-Saharan Africa and South Asia. And the recent cuts that we're all aware of, the recent cuts in health funding globally, they do threaten to reverse some of these gains. So sustained investment is critical to ensure that we don't go backwards. And then lastly, the burden of non-communicable diseases and metabolic risks are rising. NCDs now account for nearly 2/3 of the global DALYs. This is very different from 10, 20 years ago. And the DALYs due to metabolic risks rose by 31% since 2010. And with the age standardized rates, so the rates of high BMI and high fasting plasma glucose have increased in the last 15 years. And also mental disorders the burden of mental disorders seem to be rising globally. We've estimated the largest increases since 2010 for depressive disorders of 26% and anxiety disorders of 63%. So these are very large increases. And the mental disorder burden now seems to peak among youth, aged 15 to 19. Previously, we estimated this occurred in middle age, where, life gets quite difficult. But now this is occurring in youth, and it's an adolescent problem. And so, this is, I think, needs a lot of attention, because these people, these youth are going to then, they're going to be adults soon, and with a history of mental health issues. So I really think there's something that we need to. This is an issue that I think needs more attention, definitely. So health systems must focus on NCD prevention, early diagnosis, chronic disease management, and as well begin addressing this mental disorder burden, especially for youth. Again, because one of the things I'm a bit worried about is what is this cohort going to look like in 10, 20 years? Now, there are limitations to GBD and avenues for future research. So, there's often for several conditions, we might be limited in our geographical coverage of different conditions. So we might have mental disorders is a culprit of this, where we often don't get much data from, for example, sub-Saharan Africa, on the prevalence of a mental disorder, or bipolar disorder, or so on. And so, we do what we can with our methods to try to estimate for locations where we don't have data, but we're always trying, we've always got efforts to try to compile and update our data sources and get as much data as we can. And then where we have data that doesn't quite align with our case definition, we're always trying to find better ways to control for that data, to standardize that data and control for measurement error. We've also, one of the biggest limitations of the YLDs that I feel like isn't talked about as much as it should be is the severity estimates. So for many conditions within GBD, the severity distribution for YLDs, for the non-fatal conditions, is informed by one survey in the United States. And this is just because there's very limited data on the severity of lots of different conditions at the person level. There's very limited data sources on this in a way that meets the criteria for GBD. And so, we're always looking for additional data sources or alternative sources to inform this by location. And we've begun work kind of simulating how severity could change by healthcare access quality. So watch this space. Another area or another limitation is our comorbidity correction. At the moment, we do what was called independent comorbidity correction. So we simulate independent comorbidity, which says that your chance of having your probability of having a condition or a disorder doesn't change depending on what other conditions you have. And we know, for example, that's not true. Again, on the mental disorder side, we know that if you have an anxiety disorder, you are way more likely to also have a major depressive disorder, as well as several physical conditions. But when we do our simulation, because, for computational reasons, for the amount of conditions that we're doing this for, it's just not feasible yet. Maybe in the future, we've been looking into it again and again and again, but at the moment, it's not computationally feasible to incorporate what we call dependent comorbidity to say, oh, this person has depression. Okay, they are now 30% more likely to have, or that 30% of them have anxiety disorders, and 20% have also diabetes, for example. We just don't have that capacity, it's not computationally feasible yet. And then we're also looking at, there's a lot of work going on in the forecasting space at the moment. So we're trying to, at the moment, GBD, does a lot of work estimating what is the state right now and what is the state of the past. But a lot of people want to know, well, what does this mean for the future? And that's not a ready result for GBD, but there is active work ongoing for forecasting scenarios for many of the conditions in GBD. And again, it's a area to watch. Watch this space. And that's it from me. I'll stop sharing. Johan, do you want
Yes,
to take
thank
a
you
few
so
minutes
much,
to share?
Damian. Thank you for that very interesting presentation. And it seems like we made it through despite some technical difficulties. So I appreciate everyone hanging around with us. We have a number of questions already in here, but just as a reminder to those of you who are participating, please put your questions in the Q&A function, and we will respond to them. I will start here with a question asking, were there notable changes in non-fatal burden patterns for indigenous or regional populations? And how can local health systems use these findings for targeted prevention? And I think adding to that is like, to what extent are we tracking that in the GBD?
So with the GBD, we don't track specific indigenous populations. We do keep our modeling to kind of the either national for many countries or the subnational kind of administrative level, like a state or a province. We don't go to that level of detail where we're looking at very specific subpopulations. I do know that there's some more kind of local burden of disease work within GBD where they kind of venture more into this space, but unfortunately, I'm not familiar with that side of the work. Within GBD, it is much more of a that kind of higher level, larger population perspective. In saying that, if I've seen some people when they want to apply our estimates from a local perspective, they might make some of their own assumptions, like they'll bring in the national estimate or the state estimate, and they might have some assumptions about how that might vary based on some of their own local information. I have seen that happen, and that would be up to whoever's using that data and what purpose that would be for.
Thank you so much. Another question here. With over 35,000 new data sources incorporated, how does IHME ensure data harmonization and comparability, especially across countries and different health reporting systems?
So we try to do tremendous efforts to standardize that data, mostly from methodological constraints. So, and I apologize that most of my examples are on the mental disorder side, just because that's my space, but they will be applicable to the other conditions. But like I mentioned before, for some studies might use a symptom scale or different different diagnostic criteria or different diagnostic scales, or maybe they sample differently. Maybe they're not doing maybe they're only looking at schools and not looking at the whole population for a childhood disorder. So what we do is we try to match for each of these types of data sources. We will try to match that data with gold standard data or data that we are very, very comfortable, confident that it's measuring the criteria, the case definition that we're trying to model, and we will quantify what that bias is. And then once we've quantified that bias, we'll apply that to all of our data, all of that type of data. We will then inspect to see if it makes sense. And this is where I acknowledge that for some conditions, sometimes these biases will vary by geography and location. The mental disorders it's a big issue for the mental disorders. It's an issue that keeps coming up for the mental disorders, for example, because of the cultural variation in the way that people present. What might be seen as odd in one culture might be very normal in another. And we try to, in that instance, we try to see if they've used like a locally translated tool. We try to see if how the estimate stands against the rest. So if there's a study conducted in a location, and they've used a Western tool, but it's a non-Western country, and the prevalence is 3 times higher than what we're expecting, it makes you think, it's probably not valid. So we're constantly looking at how does the data fit? Does it make sense after these corrections?
Thank you so much. We have a couple of clarifications here as well, asking to confirm. I'd like to confirm that YLLs are calculated in relation to the same standard age around the world, i.e. same standard life expectancy used in Africa, Europe, etc.
Yes. So it's the idea here is that it's the highest observed life expectancy for a population. So from memory, unless it's changed recently, I believe at least it was a few rounds ago. It was females in Japan, I'm pretty sure, but I haven't checked it recently, so I don't know why they would change it, but unless there's been a major change update. But it's basically the highest observed life expectancy, and they say, yep, we can see that a group of humans can possibly live to this age, and we're going to hold everyone to that standard. Anything lower than that, anywhere in the world, and by time and by sex, we know that people can live, or a group of people can live to this age group. So let's try to get everyone there. And anything lower than that is a loss.
Thank you so much. Another clarification saying you mentioned that the data could represent either counts or rate all ages or age standardized. I've looked into the data in the GBD tool on the prevalence and incidence data as numbers for all ages. Could you please clarify whether they represent crude counts or crude rates of prevalence and incidence?
So is that the if you click counts, it'll be the estimated counts. So it'd be, you go to a country, you click counts. If you go to prevalence or incidence, it's the number of people with that condition or the number of new cases of that condition. It would be important to check the case definition though for your cause. For example, for many of the conditions, we're estimating point prevalence, which is at any point in time during that year who had that condition. So when you look, for example, in 2023 for anxiety disorders, it won't necessarily be how many people have had anxiety disorders in 2023. It's at any point in time during 2023 who had an anxiety disorder. So that number will be smaller than the total number of people who've experienced anxiety disorder in 2023. Some of those people could have remitted towards the end of the year. Some of those people could have started the year without anything and then developed it later in the year. But our estimate will represent point prevalence at any point in time who has that condition. And sorry, and there was another point to that. The rates will be rates out of the population. While I have this opportunity, one of the most common mistakes that I've seen, and I would say 1 in 2 queries I get about downloading results or inquiring about results on prevalence or incidence of the disorder from GBD Compare or the results tool, when you're downloading these tools for prevalence and incidence, don't select percentage, select rate. The percentage, when you look at prevalence and percentage, it's actually the percentage of all cases of anything rather than the percentage of the population. Now, in GBD, we estimate that about 95% of the population has something. So usually these numbers are about 5% off, but selecting percentage won't be an accurate reflection of the prevalence rate. Click rate instead of percentage if you're trying to get prevalence or incidence.
Thank you. We have about 5 minutes left here, so we're going to see if we can get through some of the remaining questions. How does IHME plan to support subnational and regional modeling so that local epidemiologists can adapt GBD estimates for implementation research?
So we do have, unless there's a misunderstanding, we do have estimates of subnational for some locations. Usually that rule as to whether we start modeling for subnational locations, it depends on the population size of the country. The reason we do that is because every time we include subnational locations for a particular subnational locations, it's quite a large lift. It's from across all the teams in GBD, all the disorders. Everyone's revisiting all their data sets to ensure that they're assigning any national estimates to that location. It's a revisiting of the internal kind of pipelines. It's instead of for the US, say for example the US, only because I don't know why I'm thinking of that example right now, but it's one of the first ones we did subnational estimations for. Maybe I'll pick a different one, like Saudi Arabia, which is a recent addition. That's a better example. So, for every, well, no, because I don't know. No, I'll go back to the US because I know on the top of my head, there's 50 states. So say, for example, we weren't going to model the subnational location of the US. We would only have one location or one kind of fit in our modeling to estimate for. Once we split that into subnational locations, that exponentially increases from 50 to 51, both as the country and all of its subnational locations. So it's quite a big lift to do. And so at this stage, we only do that when countries reach a population threshold where we say there is a clear global benefit to, or need for this in order to get granular estimates. In saying that, I think there are some instances where IHME will do subnational estimation for a particular location, but that's usually under negotiation with the government of that country.
Thank you. We are getting towards the end, so I'm going to pick something here that's kind of nice to end on, which is which regions or countries in the world still pose the greatest challenges for data collection in burden of disease estimates, and how does IHME work to address those data gaps in those areas?
I would say almost everywhere outside of high income, outside of the high income super region. Especially, sub-Saharan Africa is somewhere where we've always very keen to get more data from. But almost everywhere outside of the high income GBD region, it very much depends on the cause. Some causes will have lots of data for particular regions, but if I'm going to give you a high level answer across the board, I would say definitely anywhere outside of high income GBD super region, and definitely sub-Saharan Africa in particular. The way we try to address this is when we do our systematic review updates, we're actively looking for this type of data. If the data is not eligible, we might try to keep it aside and see, are there any bias corrections or anything we can do to incorporate that data? Often we can't, but we'll do what we can. We'll reach out to collaborators in IHME. So if there's any collaborators here, for example, that are from, I've mentioned sub-Saharan Africa a lot. If you know mental health, if you're aware of mental disorder data, as an example, because I'm from the mental disorders team, in your region or your country that we're not using, send it our way. We're always very welcoming to this data. And then sometimes we'll do targeted searches. So if we're doing our modeling and we're seeing that there's a location where we don't have any data for a particular region, we can say, well, let's do a targeted search for that location. But it doesn't always reveal anything, but we try our best.
Thank you so much. We have reached the time limit for this. I realize there are a couple of questions still pending in the chat. I will say, for any of you who feel like you have a question that you still would like answered, please do contact us. You can do that either to gbdsec@uw.edu, or by you can reach out directly to one of us. We are going to share a recording of this via the GBD collaborator portal, as well as for the other sessions that we're holding in this series. But to close out here, I'd like to thank all of you for joining us today and for your participation in this session. It's impossible for us to create the GBD without the collaborator network. And the work that we do together goes a long way towards clarifying the nature of health challenges that we face. And these kinds of discussions, the feedback, the questions, the concerns that we get from these is incredibly crucial to finding solutions to the challenges that we face when we create the GBD. As I said, once this series has been concluded, we'll share a recording of this as well as all other sessions via the collaborator portal. If you have lingering questions or you're struck by some esprit d'escalier and tomorrow you realize that you have a question that you wanted to follow up on, please do reach out to us. We'd be more than happy to find an answer to anything having to do with this presentation or anything else you might have that you're wondering about. And if you are interested in collaborating closer with us, whether it comes to data, authorship, etc., please reach out. We're here to help and we want to work with you. So a great thank you to Damian for your presentation. Thank you to everyone who attended. And we look forward to having you with us for the other sessions. And on behalf of IHME, have a great rest of your morning, day, or evening, as the case may be. Thank you all.
Thank you, everyone.